what's important about this slide is that clinically, this shows that we treat patients in a variety of ways doing many voluntary exercises. So in essence, what we're really doing is if we're trying to teach a reaction, we're really getting, more of an anticipatory postural adjustment rather than a reactive. So let me give you an example. You can take the person on the balance board who's she's looking down at her feet and she's in the parallel bars. We can do this in the clinic. We can take a balance board and put a patient on it and ask them to shift their weight anterior, posterior, or medial lateral for that matter, and see if they can let go of the bars and maintain their balance. Now, if they are going to fall, a lot of times what my patients do is they grab for the bar instead of taking a step. So then we have to try to adjust it to put the balance board in the middle of the room. But at that time, they still, if they're going to fall, they're not quite trying to make the adjustments necessary in the appropriate amount of time to stay on there. And I end up catching them in my gait belt. So what I find is that people are thinking a lot. They're using their cortex, their brain to say, what am I supposed to be doing? How am I going to figure this out? When really a compensatory postural adjustment, which is what we want to, facilitate in these patients, because that's real life out in the environment, is very difficult to achieve clinically. Again, if you wanted to strengthen your knee, you would probably do exercises for the quadricep or the hamstring. It's kind of the same thing in the clinic, trying to get that postural adjustment, whether it be anticipatory or compensatory. We can get the anticipatory. It's just very difficult to get the compensatory. I do remember once having a patient that I was trying to teach to take a step backwards so that when he started falling, he could initiate that. We worked very hard on backward stepping, all this kind of stuff. And then one day, and it was only when I owned my own clinic, because I think a lot of times physical therapists and other therapists are afraid to let go of the patient for liability reasons. We don't want the patient to fall, break a hip, or hurt themselves in another manner. But I had this patient and I gave him a force backwards and he started to walk backwards. And for the first time, I hung on to the belt, but it took me the whole length of the hallway for him to almost in some manner run backwards a little bit, trying to catch his balance. And I thought, oh gosh, at the end, I'm going to have to hang on to this larger man and assist him up. He finally took a step, probably after about 25 steps backwards. But that was the only time I actually was brave enough to do that clinically. And I think that man did benefit from that. However, that's not a safe way that's not how we're trained. That's not a safe necessarily way to do it. But a lot of my exercises were geared more towards the voluntary muscle, strengthening reaction, or, control of sending him home with the home exercise program he could do. So I just find that clinically we're so limited just with the equipment that is shown in the picture to effectively treat a compensatory postural adjustment or reaction.
Okay, thank you very much. Okay. I think you actually brought that in some of your examples as well, some of these points here. And the patient safety aspect, we have to, if we want to, within the clinic, introduce perturbation, we have to think about patient safety. That's foremost, okay? Obviously, we have to be able to do treatment customization because patients have different abilities, okay? And once we've found the correct perturbation intensity or the correct protocol to give that unexpected perturbation, then we've got to be able to repeat it. And we've got to do that objectively, and we've got to document it objectively to be able to follow up. Obviously, we've got to be able to do perturbations in standing and gait because people fall during gait and they also fall during standing, okay? And as well as you said, patient safety, logistically, we haven't got a finite time to treat our patients in the clinic. So, we've got 35, 40 minutes, maybe 45 minutes, but, we've got to get them up, working and training as quick as possible. And of course, we have to have a price tag that a community-based clinic can actually handle. So that's very, very important. So I think these are very important points. Just before we actually go into more of the looking at some clinical case studies with the system, just want to just do a little bit of a literature review, really looking at how expanding on where the literature has come from and which directions. So from about 1979 to today, there's been a surge in papers looking at unexpected postural perturbation. So looking at things like EMG studies to try and characterize different muscle coordination strategies. Looking at which areas of the brain are involved in doing a reactive response. And actually looking at the results of a reactive response, the actual strategies that are involved. When is there a crossover step? Or when is there a forward step? What do they look like, these forward steps? What are more effective forward steps or side steps? So there's a large amount of literature out there looking at postural based balance training. Just to sum up, the definition of what is postural based balance training is a specific task intervention, so a way of giving that unexpected perturbation, aimed at improving reactive balance control after we've already challenged the patient with a loss of balance, if you like, in a safe and controlled environment. So we have a very good, if you like, summary of what we're trying to achieve when we're looking at perturbation-based balance training. And here we have the BalanceTutor. So we'll look at this in a little bit more detail about what's actually happening. We said at the beginning, but we have this ability to laterally move the BalanceTutor to the left or to the right. And we can also do that while the treadmill is moving. So we can, if the treadmill is not moving, then we could be working with in the standing while we're standing. Okay, and it's computer operated. So this allows us to do objective, if you like, settings of perturbation intensities and also reporting. We have the harness, which is patient safety. What's very important is this is not a body weight support system, okay? So perhaps when you do a perturbation, the patient might use that to stop them falling, and that might be a body weight support, if you like, but it's not designed as a body weight support system, okay? It's designed as a protective harness. Okay. Now, we can also have a look at some other aspects of what we can actually train or why we should be thinking about using perturbation-based balance training and why we're using, what are we doing when we're using unexpected perturbation? Okay, so what I'm going to show you is, and it's going to be quite clear to you, and already should be quite clear to you, that if you're challenging our patient with unexpected perturbation, then you're going to challenge the sympathetic nervous system. That reaction, that reactive response is obviously challenging the sympathetic nervous system. If we're doing traditional exercise practice, then obviously we're working very much within the comfort zone of our clients. So we're not going to challenge the sympathetic nervous system. Okay? So I'll just show you this, and I think Amy likes this this video, right? Where we can see an amazing instinct-like response of this person. Obviously, he's getting that sensory information. What's the sensory information? That's visual sensory information, and he has to react. So he has to use a lot of muscle strength and muscle, if you like, burst speed to be able to get out the way of that car. And obviously, we can understand that the sympathetic nervous system is very much going to be involved. His heart's definitely going to be beating quickly after that. Okay. Right, Amy. So, do you want to talk a little bit about vestibular, how we can challenge the vestibular system when we're looking at perturbation and unexpected perturbation?
Sure. So here you see a patient on the BalanceTutor, and she's receiving a looks like a lateral perturbation. And what happens with the vestibular population is that what we're really trying to do or accomplish with these patients, I should say, is that we're trying to activate the neural firing in the vestibular system, and we're trying to get the patient to kind of adjust, or what she's doing is react and hold their balance and get that vestibular system to uptrain, so to speak. This patient's actually doing quite a great job, given the fact that she does have vestibular issues. A lot of times in our clients, we'll see a delayed reaction response, just because their sensory information isn't quite kicking in like normally, a normal person would. I think in the previous video as well, you could see the patient's, or the person's head movement really kick in to accommodate that reactive response when he was avoiding the car. And in this video, you'll also see how important the head is in maintaining and some of that postural positioning that we're going for, so she doesn't lose her balance. What's also interesting about this is that not only can we stimulate that vestibular nerve, but we're also getting all the other important reflexes for postural control stimulated at the same time. The repetitive motion will allow this patient to finally learn a little bit about, in a safe environment within her ability to perform it, the exercise that is, but it provides. I'm losing my thought, Ellen.
It's okay. I just interrupt. It's we yeah. For all our audience, it sometimes gets difficult to be on camera, but okay. Yeah, I think what's important. There's a couple of things. What you just said was quite interesting, because I hadn't really thought about it. That the head, obviously, with gravity, it's quite heavy, isn't it? So actually using shifting the position of your head relative to your body is going to be important to actually stop you from losing your balance. So the way you can do that, obviously, is some sort of a VOR, isn't it? It's a vestibular reflex to keep your head positioning. So I hadn't actually thought about that before. I think my interpretation is a good interpretation. Is that what you sort of meant?
Yes, the head is pretty incredible, the way it plays its role in balance and the way people react with their necks. So it's not only, we're looking obviously at the vestibular nerve, but we're also looking at, to make sure these patients don't have any orthopedic issues or whiplash issues with their neck if they've been in a car accident and such.
Okay, so we can actually talk about that later on, where you actually gave an in-service with your staff and looking how you can actually look at using the BalanceTutor for some traumatic injuries as well. So that was maybe something that you can talk about later. But I think an important point is that if we ask our client to move their head, they're very much going to be doing that within their ability level. Okay, so by able to give perturbations, we're giving an external force which is moving the head more quickly. So obviously we're going to increase the firing of that vestibular nerve. Okay, so we're going to increase the amount of afferent information, and obviously that's where we got the sensory integration coming in, because you said there's lots of other information coming in as well. You've got the proprioception information coming in, the visual information coming in. So we're getting all this sensory integration. So we're actually challenging, if you like, all of the sensory integration. Okay. And this is an interesting slide as well, isn't it? Do you want to discuss, obviously, why we've got a soldier here and we got a basketball player on the right-hand side?
Yeah, so we have the type 1 slow twitch fibers. I think that's a great picture of somebody who stands still pretty much all day long and has to basically just maintain their balance and standing. So it doesn't take a lot of effort regarding the muscles. He probably will do some adjustments in his ankle, using his ankle just to maintain his center of gravity over his base of support there. However, you know, in the other picture, the basketball, the type 2 fast twitch, that's also a nice picture showing how quickly with, you know, high loads, as it says, that the muscle needs to contract and the brain needs to coordinate that type of movement pattern. So it's just a good slide to remember that we can train both type 1 and type 2 muscle fibers when we're doing compensatory postural reaction training.
That's right. And I think this is the next slide. This is where we get the adage, use it or lose it. I mean, we just said, where are you going to train the sympathetic nervous system? Where are you going to get that maximum head acceleration? Where are you going to try and exhibit, if you like, the clients to use or get them to use their fast twitch, their type 2 fibers? And if you don't, you're going to lose it. So we have to be able to look at trying to challenge as efficiently as possible our patient. Otherwise, they're going to lose that ability. Okay, so I think that's the use it or lose it for all these aspects. Okay, and what you said was quite interesting, because you've actually brought onto that slide the soldier, if you like. There's a little bit of compensatory or some anticipatory postural adjustments going on the whole time. Okay, obviously, as you said, very slow twitch muscles, so not using a lot of strength and you know, speed of muscle movements. But if we, and as we can with the BalanceTutor, customize the perturbation amplitudes, we can actually target different reactive responses from different parts of the body. So if we're using a small amplitude of perturbation in a medial or lateral direction, or a low intensity perturbation, then we can actually get the patient as much as possible, if they have the ability, to do dorsiflexion and plantiflexion to actually keep that base of support, to keep their center of mass within the base of support. If we increase those perturbations still further, then those ankle strategies are not going to be enough. We're going to have to introduce more of the whole body. Okay, so more of the hip, more of the trunk. So we class those as hip strategies. And then if we increase those intensities further to maintain that center of mass within the base of support, we're going to have to do some sort of a compensatory step. So that could be a crossover, or it could be a forward step, or it could be a backward step, depending on the intensities and directions of the perturbations that we're going to initiate. So being able to customize those levels of perturbations, we can target different strategies or different parts of the body, and that could very much be related to our goal. For instance, if we had a stroke patient and we had some deficits in dorsiflexion, trying to encourage them to do dorsiflexion as a reactive response could be a particular goal of ours.